Thanks to Dr. Nagarjun for having me here. So I think most of you are eager for this lecture because I am the one blocking you from lunch. So I think I'll keep you awake till you go for your lunch. So I'll be discussing what is PROS, why should I learn it, where did I begin, and what should I learn as a pulmonologist, and how to learn. So I think the need for rapid onset evaluation has been discussed adequately in the previous lectures. So while several things have been said about it, it's not really proven that it improves the diagnostic skill. For a given patient, yes, it does help. But anyway, it does add to the cost and depends on the availability of a cytopathologist. And several sites may not be privileged to have a cytologist on your bronchoscopy room. So hence, the jack of all trades decided to take up the job. So when I first joined my undergraduation, this was what was shown to me as eosin and hematoxylin. And from there, I learned to identify slides. If it was broken in one corner, it was a cartilage. And if it was broken in the center, it was a lung. Unfortunately, this does not work now. Now my seniors asked me to check whether the slide is adequate and is it diagnostic. So the second question, is it diagnostic? I think it is straightforward. We would be looking for only two diagnoses in our bronchoscopy suite. Is it a sarcoid or a TB, which is a granuloma, or it is malignancy? So we need to identify only two things. Is there a granuloma? Is the cells normal or abnormal? So it seems quite simple, but let's see how it goes on. And the most important question is whether the slides is adequate. Our technique has not been so good that we don't even hit the lymph nodes right on most occasions. So what we need to learn? The first thing we need to learn is the individual cells, how do they look like, and the cell clusters, which could include the diagnostic ones, that is the granulomas and malignant cells, and the contaminants, which are the respiratory epithelial cells. And we can sometimes get information from the background. So I will be using the slides which we had done in our EBUS TBNA and was sent to the cytology department for further evaluation. So these are well stained and good quality slides which obtained from the cytologist. So what we see here is in the background we can see the blue ones are the RBCs. And the other brightly stained structures are the lymphocytes. Sorry. So this is a hyper magnification to show the lymphocytes, how they look. They are almost the size of the RBCs. And I think this is not difficult to identify if you have a look at the slides repeatedly. Next, we can find lymphocytes in varying sizes also. So these should not be, is the pointer working?
Dr. Valliyappan, you can use your pad for.
Okay. Okay. Yeah. So here we see the lymphocytes in varying stages of maturation, the small and large ones. Okay. This is our good friend, which we should not be seeing in our slides, the respiratory epithelial cell, which is a ciliated columnar epithelium, the pink, the brush-like border. This is the respiratory epithelial cell, how it will look like. So I have shown individual cells here, but when it occurs in clusters, it might cause a lot of confusion. So here we see another respiratory epithelial cell, which is well stained, and this in the center is a macrophage, which is large and bizarre, and the others in the background of the RBCs and these lymphocytes. One more section to show the good macrophages, which are large and slightly bizarre, and these are the column of respiratory epithelial cells, which are not supposed to be here. So another slide to show the macrophage, and this I learned only recently. This large looking macrophage, which has eaten up the nearby dead debris, is called as the tingible body macrophage. It is supposed to be a representative of germinal centers, and it suggests that we have hit the node accurately. So these are some things which are uncommonly found inside a lymph node. These are identified by multiple multilobulated nuclei. This is the neutrophils. Occasionally we might see this. So these are the individual cells which I was talking about. Then we go to the background. So we can sometimes find the respiratory mucin. which is over here. So it might not hold direct relevance for us. It's just good to know what this mean. But for a cytologist, this might give more information, and a mucinous adenocarcinoma can also have such kind of background. So here in this slide is a background of necrosis in a patient with malignancy. And here there's some necrosis in the presence of granuloma. I'll talk about the granuloma when I talk about the cell clusters further. So this is how a cartilage looks like, acellular, pink, and this whitish sieve-like appearance. So once in a while, if we do an EBUS, especially the first pass, we might encounter this cartilage either in the entire slide or in bits and pieces. So then we come to the more relevant ones, the cluster of cells which we can find. So as has been said by previous speakers, this can easily be mistaken for an abnormal cluster of cells. But whenever we see a cluster of cells, we should try to look at the individual cells which lie at the background. See here, if we can see the cilia or the brush-like pinkish cilia is clearly seen. So this cluster should not be labeled as abnormal, and it's most likely a respiratory epithelial cell cluster. And this slide is of course inadequate, and we need to proceed further. So this is a granuloma, again a collection of cells. I do agree all of them look similar on first look, but what we need to look for is the slipper shaped cells. This is the elongated epithelioid cells. If you have a cluster of cells and you find no respiratory epithelial cells and slipper shaped cells like this, that is the key feature of a granuloma. So this is a malignant cell cluster. So how to identify them? Yeah, of course, it's another cell cluster. It has a high nucleus to cytoplasm ratio, more darkly stained. In simple language, so I asked the pathologist to forgive me for the layperson interpretation of these colors. So this is a darkly stained nucleus with multiple nucleoli sometimes. A more closer view to appreciate that the cell almost seems to be containing only the nucleus. These are large, irregularly shaped with multiple nucleoli in some of them. So we need not, as at least as pulmonologists, if we can find out what is abnormal and normal, that would be sufficient. But in case with experience, you might be able to recognize some features which could say whether it's a non-small cell or small cell. Molding is nothing but the nucleus seems to fit into each other so well that they mold into each other and they fit into perfect pieces of the jigsaw. So how to train ourselves? Unlike radiology training, which is another job which I have undertaken partly, interpretation and analysis of cytology is not part of a curriculum. So we should train ourselves, supervised by the cytologists and cytotechnologists, in making slides, staining them, and formal lectures from them. And it's said that at least 3 months of training with 3 to 4 hours in a week is at least required for a decent interpretation of these slides. So what do we follow at our bronchoscopy suite? So for each pass that we take, we obtain at least one air-dried and one alcohol-fixed slide and transfer the remaining material to the cell block and the saline sample for culture and other ancillary investigations. The air-dried slide is dipped in a rapid MGG stain. So we used to use the rapid HNE. It was a little time-consuming for us, which this one is was quite easier. So we shifted ourselves to MGG stains. I'll show how these slides look like, and not as good as the HND stains which I have been showing right now. So once they are dried, we view under the microscope. So this is what the chairperson had previously told. We use this at our site. So previously, once we identify the cells, we click a photograph of the relevant areas and we send it to our telecytologist. To our cytologists who say whether this is adequate or inadequate. So these are the poor quality images, as you can see, which were prepared by us. So we had clicked at least the right portion and sent it to them. This was a granuloma. This was a malignancy, which in the next specimen they had confirmed from their own slides. So as our experience grew, we did more and even stained the brush cytologies. So the bottom ones are brush cytology from fungal infections showing hyphae. So this is a malignant cluster which we identified, which they confirmed later with the proper pap smear which they had done. So how did this poor man's cytology and the poor man perform? So as expected, the P rose or the pulmonologist rose was not very good as compared to the final slides in terms of adequacy and in diagnosis. However, when we had the diagnosis vetted by the cytologist in through WhatsApp, our performance had become much better. And as again expected, with final cytology, our correlation was pathetic. But anyway, at least the adequacy we improved over time, and with the confirmation from them over WhatsApp, which is right now available in 2 or 3 minutes. So we are increasing our more sampling based on the response we get from them. So my questions don't have answers because they are quite easy. And since everybody wants to go for lunch, I asked them to answer quickly. So what hyphae is this? Septate or aseptate? Yes, that's what we also did, but this was a cotton thread which we mistook. And this is another cluster of cells. Can someone identify what is this cluster of cells? Yes, we made it as a granuloma. Of course, from the WhatsApp, it was confirmed that it was a respiratory epithelial cell cluster. The last question for today, another cluster of cells. Anyone? No one? Granuloma or malignancy? Respiratory epithelial cell cluster again. So this was again an inadequate smear which we had to repeat it further. So learning PROS requires time and effort. It might appear simple, it's doable, but it takes time and effort. Systematically review the slides. We often jump into a cluster of cells and we miss the remaining part of the field. So we need to go systematically follow either a zigzag pattern or whatever pattern which suits one. First screen in low power, it saves time, and then select the area in the higher power and get it confirmed and obtain a feedback. So finally, brothers and sisters of Hyderabad, ROSE, PROS, and stop not until the diagnosis is achieved. Thank you.